Hello, everyone. My name is Ufoma Oibororo, and here at the School-Based Health Alliance, we would like to thank everyone for attending today's webinar titled Beyond the Pill, Part 3, An Ethical Framework for Providing Contraceptive Counseling. Today's webinar is the last of a three-part webinar series. During today's presentation, attendees will have the opportunity to explore ethical care and counseling. Before we begin, if you are viewing as a group, please open a chat window by clicking on the chat icon and type in the name of the person registered for this webinar and the total number of additional people in the room. This will help us with our final attendance count. The School-Based Health Alliance is the national school-based healthcare advocacy, technical assistance, and training organization based in Washington, D.C. The School-Based Health Alliance works to improve the health of children and youth by advancing and advocating for school-based healthcare. As youth-friendly and accessible settings, school-based health centers are uniquely positioned to deliver high-quality, confidential services that equip children and adolescents with the information, tools, and support they need to be healthy and safe where they are when they need it in school. We believe that all children and adolescents deserve to thrive. When health and education come together, great things happen. Now we have a few housekeeping reminders. All attendees are in listen-only mode. However, we want to hear your questions. To ask a question at any point during this webinar, please use the chat tool located in your Zoom control bar. We will address questions following the presentation. Also, at the end of this webinar, attendees will be asked to complete evaluation poll questions. Please let us know how we are doing. Your feedback is vital in helping us craft presentations that meet your needs. This webinar is being recorded and will be archived on our website in 1 to 3 business days. Please also visit the School-Based Health Alliance for additional archived webinars for topics such as the ones you are viewing on your screen. Now I would like to introduce our presenters for today. We will be hearing from Connie False and Nina Pine, contraceptive training specialists with the Bixby Center for Global Reproductive Health of the Department of Obstetrics, Gynecology, and Reproductive Sciences at the University of California, San Francisco. Nina?
Hi, this is actually Connie. Real quick, I'm just going to introduce myself and then hand it over to Nina because she's going to be starting us off. Again, my name is Connie Fulf. I am a contraceptive training specialist with the Beyond the Pill program at the Bixby Center for Global Reproductive Health, which is like a mega mouthful right there. And I've been with this program for like 6 years and excited to be here today to talk to you guys about this very important topic.
Absolutely. Thank you, Connie. Hopefully everyone can see my slides and that is all going well. I like to joke, is it even a webinar if we haven't had at least 4 technical issues? But good morning or good afternoon, depending on where you are. Like I said, my name is Nina and I work with Connie at Beyond the Pill. I'm a contraceptive training specialist, and so we are here today to deliver a webinar on the tiny topic of an ethical framework for providing contraceptive counseling. We also just really want to thank the School-Based Health Alliance for having us here today, and we're very excited to be with you all. So as Usama already mentioned, we are a program of the Bixby Center at the University of California in San Francisco. And Beyond the Pill's mission is really to promote access and equity in contraceptive healthcare. And we do that through research, through educational materials, and through trainings just like this one. So really quick, this is just to note that Connie and I don't have any financial relationships to disclose, and neither does our planning committee at Beyond the Pill. We also just want to take a moment to thank our expert reviewers. Each of them have provided really critical input and feedback to help us improve our training curriculum, so we just want to acknowledge them here. We also want to thank our funders. So beyond the pill, we've trained over 6,500 providers across the mainland United States, as well as in some of the territories. And these providers that we've trained serve about 2.1 million female contraceptive clients annually. And we absolutely love training at school-based health centers. So if you're interested in learning more about our full training today, feel free to go onto our website. It's there in the little teal box, beyondthepill.ucsf.edu, and you can learn a little bit more about that. So let's dive in. We've got about 45 minutes today with each other. So we're going to do our best to cover these objectives in a super timely manner. We're going to describe how to apply an ethical framework that's informed by reproductive justice to contraceptive counseling. We're going to talk about implicit bias and the outcomes it can have on our contraceptive care. And we're also going to look at some patient-centered counseling approaches that we can use to help support our patients' autonomy. So let's dive right in, and we're going to start off by introducing you to our client, Keisha. This is a client case that we're going to be referring to throughout this webinar today. So participants, meet Keisha. Keisha is 19 years old. She has one child and uses she, her, hers pronouns. She got a copper IUD about 2 months ago and is really unhappy with the heavy bleeding she's got. She comes into the clinic and says, I want to get this IUD out right now. So what we're going to ask you to do is imagine Keisha as a patient of yours. Let's just pretend that she's sat down in clinic next to you. She's telling you about the heavy bleeding and these symptoms, and she says, I want this IUD out right now. So our question to you is, do you want Keisha to keep her IUD? And I want you to chat in your responses to the chat box, please, and we really want to challenge you here to give us your honest feedback. Give us your honest gut response. What's your first immediate reaction to hearing the story from Keisha, from working with a client like this? Just let us know in the chat box what you would say. And Connie, if you wouldn't mind reading some of those out for us, that would be fabulous.
Sure, I just had to figure out how to unmute myself here. I see someone has said that they do want Keisha to keep her IUD today because she just got it, essentially what they said.
Great. Anything else?
I see I would like her to keep it because she needs some more education. Well, and she needs more education and guidance around side effects. And then someone else said, I would like for her to keep it, but it's not about me. I need to make sure I'm not trying to talk her into it when I'm talking about the situation. And then another person said, no, she wants it out. It has to come out. If Keisha gives permission, the provider can discuss managing the heavy bleeding. But if she still wants it out, the provider must honor that ASAP.
Brilliant. Thank you. And thank you, everyone, for chatting in. Something that I've often heard in response to something like this as well is, definitely had this patient before. I swear we went over bleeding changes and side effects for like 10 minutes. And then they come back 2 months later and they're surprised by this, but it's like, oh, we talked about this. So that's something we hear a lot as well. So some of these thoughts that are showing up in our cute little word bubbles here, or thought bubbles, I should say, have already been kind of covered in your responses, right? Where we could do stuff to manage the bleeding. It's only been 2 months. It's too soon, I believe someone might have mentioned. So these are some of the thoughts that might come up. And so what I'm going to ask you all to do is just to reflect for a second on whether any of these thoughts or anything like these have ever crossed your mind about a client. Even if it was just for a super quick second, have you had any of these thoughts before? Or have you had any colleagues that have shared this kind of thought? Or could you imagine why a provider might feel this way? If we were all in the same room together instead of on the internet, I would be asking everybody to raise their hands right now. So I'm just going to imagine that some of you are nodding along as you're contributing to this webinar. And I say that because these thoughts are really normal, right? It's absolutely normal for us to think, oh my gosh, this is too soon, or I can't believe this patient is telling me that they've got heavy bleeding. We covered this earlier. It's also absolutely normal to have thoughts like, okay, if they want it out, we're going to take it out right away. And so I just want to ask us to think about these situations and to think about these perspectives, because when we're counseling patients day in and day out, we don't only have their perspective to hold, right? We're also thinking about this from an administrative standpoint. We're thinking about it from maybe a grantee standpoint. You know, something that I know that I've thought of is, holy cow, IUDs are super expensive, and we have to turn somebody away yesterday because we didn't have any stocked, and now this person wants it out. I could have helped that other patient. These types of thoughts are things that we have consistently in our care. But I wanted to take a minute to just put a pin in that and think about that quote-unquote bigger picture or that administrative picture that we think about and look at how that might actually affect our patients. So again, just a quick reminder that we'll be working with Keisha throughout, so you haven't seen the last of Keisha yet. And so as we're talking about ethical guidelines, we want to really think about increasing access and upholding our clients' autonomy and that sweet spot right in the middle here. Some of you also may recognize this Venn diagram from Dr. Shah's webinar about 2 weeks ago, so this might be a bit familiar to some of you. And so what I mean about that is that we spend so much time working on increasing access, right? We spend time learning how we can stock our clinics. Maybe it's working with school administration to make sure that we can even provide birth control in our clinics. And we spend so much time focusing on that, but we also want to make sure that we're working hard to respect what our clients' needs are, and that we hope to achieve the balance between ensuring access and also respecting our patients' right to make voluntary decisions without any persuasion. And so we also need to note that we actually can't discuss an ethical framework on contraceptive counseling without acknowledging that reproductive coercion absolutely occurs in our field, and that unfortunately in this country we've got a really long history of coercive reproductive practices, and they typically target vulnerable communities such as women of color and low-income folks. So unfortunately, we have way too many examples of these acts of reproductive coercion. For example, some sterilization abuses in the 1970s, the Indian Health Services sterilized Indigenous women across the United States without their knowledge or consent. We also saw in the U.S. that from the 1920s to the 1950s, it was actually legal to sterilize women with disabilities and their children. And so we want to be conscious of the fact that this history is very real, and it's a part of our legacy and a part of our career in our industry. But I also want to emphasize that reproductive coercion isn't just something of the past, right? This isn't just something that happened with the birth control trials, in Puerto Rico. This is something that we still see today, especially with things like incentivizing folks to use particular birth control methods. Just as recently, actually, as 2017, we saw that in California and in Tennessee, incarcerated folks were being offered reduced sentences if they agreed to use an IUD or an implant or agreed to be sterilized. So this isn't just something that happened before, way before we started practicing. This is something that's still very much happening today. I also want to point out this down here about how there are some types of coercion that are maybe a little less apparent or they're a little harder to see right away. Some of that might include programs which will cover the cost of LARC or cover the cost of IUDs and implants for clients, but they won't cover removal, or there might be a high cost associated with removal. So at first, on paper, right, it might not seem coercive, but once the client comes back like Keisha and really wants their IUD out, there's a coercive nature in that, and that they might not be able to access that service. It might not be applicable or accessible to them because of financial barriers. And so in addition to these explicitly coercive practices, or maybe the ones that are a little harder to identify that we just discussed, we know that individuals and communities, we all experience health differently, right? And we have different levels of access to services and different access to information. And so the reproductive justice movement has been a really powerful force in addressing that discrepancy and looking at the wider social context in which healthcare actually occurs. And so hopefully some of you are familiar with reproductive justice. If not, you can go on our website and find more resources as well. But just a quick intro. This was a movement that was started in the 1990s by Black women, Indigenous women, and other women of color, predominantly in the South. Sister Song is kind of the matriarch organization, if you will, of the reproductive justice movement, and they're based in Atlanta, Georgia. And reproductive justice really looked at the concept of reproductive dignity and acknowledged that just accessing choice or just accessing services and rights wasn't enough, that we really had to look at this wider context in order to uphold everyone's right to have children and everyone's right to not have children. So reproductive justice included the concept of reproductive health, right? Access to services, making sure that everybody has access to the health information they need, but that didn't really bring it home on the justice front. And so reproductive justice also includes looking at equity and how we can increase power and opportunities for people in these institutions that play such a pivotal role in how we access healthcare. Because, as we can see here in our fun animation, is that in order to achieve social justice with reproductive health, not only should we have the right to have children, but we should have the right to raise them in healthy environments. And so we want to acknowledge that this type of discrimination, these structural inequalities in the healthcare system, and these coercive practices that have happened previously and still happen today, we know that these target marginalized communities and that they've experienced multiple forms of reproductive oppression, right? It's not typically one, that these events can compound on each other. And so this might impact the way some individuals and communities look at family planning. It might not. But it's important to note that for those that do, it could affect the way they look at certain birth control methods, or it might affect how they look at the medical community in general, or whether there's a lot of trust in the medical community. And one way that we see this come up a lot with IUDs and the implant in particular is something like this, where a client says, I don't want something inside of me. Again, I'm imagining you all nodding because if I was a betting woman, I would bet that you've all definitely heard this before from your clients. And it makes complete sense, right? The idea of having something foreign inside your body is a little bit strange, and also something that you can't control, right? Because for an IUD or an implant, patients have to come to us to get them inserted, and they have to come to us to get them out. Whereas if they had a pill, for example, that they weren't really a fan of, they could just not fill the script or stop taking it. There's kind of an inherent lack of control when it comes to LARC methods. And if you don't have a lot of trust in the medical community, or your family has experienced acts of coercion or reproductive oppression, it's completely understandable why somebody might not be comfortable with having something inside them. So carrying all of that, we want to talk about the ethical framework that we bring to that contraceptive counseling, remembering that increasing access and that upholding autonomy and how that actually plays out in contraceptive counseling specifically is that we feel like all patients should receive medically accurate and unbiased information that's relevant to them in their culture and community. Patients absolutely have the right to choose any method of birth control or to not choose a method of birth control without any persuasion from us. If a patient has a LARC method, they are absolutely allowed to remove it whenever they want, no matter what the time frame might be, without any judgment or resistance from us. And patients that need contraception for reasons that aren't about pregnancy prevention, they deserve the same level of care and respect. So for example, if we have a patient that wants the Mirena IUD to help them with their endometriosis and not about pregnancy prevention, they deserve the same level of care and respect that our contraceptive clients may need, or that we give our contraceptive clients as well. Okay, And now we're going to get into a little bit more about how we implement this framework, because I know it can feel a little bit big, it can feel a little bit heavy, and so we're going to break it down and how that actually applies and how we can use patient-centered counseling to really implement this. So I'm going to pass it over to my colleague, Connie.
Can you see me and can you hear me? I hope. Okay.
We can.
Oh, good. It took me a minute to figure out how to do all that. So thank you so much, Nina, for setting that foundation. We're going to explore now the impact of implicit bias on contraceptive care, and sort of and we'll connect these two ideas of what Nina was talking about this morning to what we're talking about in this section. So what is implicit bias? Implicit bias refers to the attitudes or stereotypes that affect our understanding and actions and sort of the way we process the world, but at an unconscious level, okay? So it's also referred to as unconscious bias. And I think in terms of connecting it to what Nina was mentioning, it's helpful to think of coercion on a continuum. So ranging from those more outright and blatant forms like forced sterilization is obviously a form of coercion, to some more subtly coercive practices. So the blatantly coercive practices really have their foundation in explicit bias, which is attitudes or beliefs about a person or a group of people that are happening on a conscious level. But implicit bias, again, is at an unconscious level, and it can really affect some of the more subtle aspects of care, including the way that we communicate with our patients about pregnancy, about parenting, and about their contraceptive options. So really, it's unconscious, and it's involuntary. It's not something that we have control over, okay? So a few key characteristics of implicit bias are that it's unavoidable. It's like everyone has unconscious biases, period. And the important thing to note is that they don't necessarily align with our declared beliefs or even reflect stances that we would explicitly endorse. So in this way, they're different from biases or stereotypes that we may have and be aware that we have, but that we choose to conceal for purposes of social or political correctness. And so many of us have those as well. But these are different, right? These are things that we're not even aware of. And our implicit biases tend to favor our own in-group, which means the group that we're a part of. So if we are women, our biases may favor women over men. But the interesting thing to note is that in terms of implicit bias, we may also favor the dominant group. So we receive messages from the world, through our whole lives, from the media, from our experiences in life that help us form these implicit biases. And if we live in a culture, for example, that is male-centric, we may, even if we're female, we may favor males over females because that is the dominant message that we receive in society. So, an example of this is I love Australian television, and there's a lot of it on Netflix, which is fantastic. It's a great time waster for me. And there's a show that centers on a female OBGYN, and she's like even like she may even be the head of the OBGYN department, and she's like about to perform a C-section, maybe in the third episode of this show. I first started watching it. And I thought to myself, goodness, like, is this an Australian thing? I was like, she has a lot of latitude for a nurse. And then I was like, oh my God, that is crazy. My brain processed it all involuntarily. It was like female nurse, male doctor. Like, what happened there? That is what implicit bias is. And that is an example of how it may favor a dominant group instead of your own in-group. So obviously, right, I'm frequently in the company of many extremely capable female clinicians, and yet my brain did this without my control. So the good news is is that implicit biases are flexible. And we're going to talk about some strategies today that can help you not only identify what some of your implicit biases may be, but then also some things that you might be able to do to help sort of mitigate the impact of them. So the point of mitigating the impact of implicit bias is so that when we're counseling our patients, we can remain patient-centered, because what happens when we have biases is that we can tend to just project those biases onto patients and end up not being patient-centered. So we really have to be willing to examine our own ideas about, are there methods of birth control that we think are better than other methods of birth control, or why? And why? And also, do we have ideas about who we think should or shouldn't get pregnant or have more children right now, or under what circumstances do we feel it's quote unquote appropriate to expand a family? And I think that these things are sort of uncomfortable to acknowledge in ourselves, but we cannot move forward unless we acknowledge them. So there was a really interesting study published in 2010 that found that providers were more likely to recommend IUDs to poor women of color than poor white women. And I would wager that it's very unlikely that any of these providers did so intentionally or at a conscious level of awareness. However, again, if we have received messages from the media or the world or our life experience that bringing a child into the world when you don't have financial resources is irresponsible or something, and we see messages like that all of the time, then it unconsciously can seep into the way that we communicate with patients. So if we're not aware that we hold those biases, we're less able to mitigate the impact of them. So really, ongoing self-reflection is critical to uncovering and working against our own unconscious biases. And we want to share with you a couple resources for doing that. One is this implicit associations test offered through Harvard. It's a really fascinating tool that you can use. And I mean, you could spend hours and hours on this website, but you can do it in as little as 20 minutes. There are lots of different tests and things that you can explore. And I really encourage everyone to take some time to check this out and to be open to the results, because I feel like it may be surprising to you what you discover in terms of your own biases. One thing that I discovered, which I find quite humorous, is that I find men who have facial hair to be untrustworthy. And I find that quite telling, because I'm basically only attracted to men with facial hair. So I feel like we could probably spend the rest of the webinar just unpacking that. So I'm just going to leave it right there and move on. But again, take these tests and you can learn very fascinating things about yourself. You may learn that you hold biases against groups that you are a member. I also found that was true of me. For example, if you are a sexual minority or gender minority, you may hold biases against your own group, because again, the dominant messaging from society favors certain groups over others. We really want to emphasize that the key is not to feel guilty about having these implicit biases, because everyone has them. And also because that feeling can be kind of paralyzing. And what we don't want to do is be paralyzed. We want to act, and we want to be able to help combat the impact of implicit bias. So get to know what your implicit biases are and check in with yourself on the regular to make sure that you're acting based on the information and the client in front of you, rather than assumptions that you may make consciously or unconsciously about them. So in that spirit, we're going to do a poll, and we're going to invite you to answer this question. Have you ever felt frustrated with a student or a patient when they did any of these things? Chose not to use birth control. I think this is a select all that apply. I'm not sure if you can. If you can, go for it. If you have to choose just one, feel free. right? When they chose not to use birth control, when they chose to continue using a method of birth control that had been difficult for them to use in the past, when they relied on emergency contraception as their primary method of birth control, when they wanted to have their IUD removed shortly after having it placed. I'm seeing lots of answers roll in. I'm going to keep letting them roll in for a second while I tell you a little story about this radish and this turnip. So when Nina and I were putting this presentation together, more than one person said, I really don't get the radish and the turnip, and I just want to know if you guys get it. I'm going to explain it to you first, which is a little bit of a cheat, and then I want you to pretty please raise your hands if you understand what it's about. So here we have a turnip, and the turnip has these ideas about himself. I've just gendered this turnip, but he has these ideas about himself. And when he looks in the mirror and he does this self-reflection, he actually sees something else reflected, and he learns something about himself that actually what he thought, right, or his declared beliefs or values were different than how he was acting based on implicit bias. Do you get it? I hope so. I hope you raise your hands to let me know that you get it, or chat in that you get it. It'll make me happy. Okay, so lots of people, we see all of these things, right? The poll responses, I'm not sure if you can see them, but all of them are hit. So it's very normal and very, very common. I guess the most popular answer was when somebody chose not to use birth control. Absolutely. It's so common to feel frustrated with patients. It's very normal, and it doesn't make you a bad person, okay? But what do we do with that frustration is the point, okay? So we know that we're frustrated. How do we handle it? Let's see if I can get control back of my screen here. I'm having trouble advancing the slide. Oh, no, here we go. It's coming, thank you. Okay, so a lot of the contributors to frustration really come from a place of caring and a well-intentioned place. And that's another reason why we shouldn't feel bad about having these frustrations, right? We want what's best for our students. And for example, the most popular answer of feeling frustrated when somebody chose not to use birth control, if you know that this particular person really wants to finish high school and wants to go to college and has all these goals, and you feel like, oh my gosh, an unplanned pregnancy would totally derail that, and yet they're not using birth control. I can, I've heard so many providers, especially with regards to adolescents, just tell me like, Connie, I just wanted to shake them. Like, why don't you see this, or why don't you get it? So it's coming from a caring and a well-intentioned place. But I also want you to consider how inherent in this frustration is an assumption that the client is making the wrong decision and that you know what the right decision is. And that the problem there is that we run the risk then of becoming directive in our counseling. And we run the risk of not creating the space for each individual client to make a voluntary choice around contraception that's free of persuasion. So if we attempt to persuade clients to use one method over another, or to use a method at all, or we try to persuade clients like Keisha to keep using a method that they're not happy with, we really run the risk of amplifying a power differential that already exists between healthcare provider and patient, where the provider holds the power and the patient's experience is undervalued. Okay, so really what we want to encourage is for you to think about it more like a dialogue between two individuals who both have really important contributions, and that we're creating a situation where we're trusting the client to make the decision that's best for them. So situations like this where we find ourselves being persuasive or find ourselves feeling frustrated with clients can really give us some insight into some of the unconscious biases that we hold. For example, with regard to feeling frustrated when someone's not using birth control, do we hold a bias that right now is not a good time for them to get pregnant? And why is that? If maybe they want to, right? So when we have these strong emotional reactions, and they could be positive or negative reactions. We may have positive reactions like, yay, she chose to use an IUD. What is that about, right? We need to think about what's going on with those strong emotional reactions, and can give us a window into what some of our biases about who should or shouldn't get pregnant, or when is a good time to get pregnant, or the relative desirability of different methods. So we know that provider-driven counseling is associated with lower patient satisfaction and with method discontinuation, okay? And what we're hoping for is instead to really be patient-centered and think about achieving these sorts of goals or elements that have recently been validated in a measure of interpersonal quality and family planning. So the elements here are, does the patient feel respected as a person? Did the provider let me say what matters most about my method? Did they take my preferences seriously? And did they give me enough information to make a decision? So we should be thinking about sort of making sure that we're doing all of these things when we're counseling folks about contraception. And one of the ways that we can do that in those situations of frustration is to roll with resistance. And I feel like probably a lot of you have already heard this term because it's a technique of motivational interviewing. What does resistance look like? I always like to use the analogy of a tug of war. So resistance can be obvious, like in their body language, right? If someone's crossed their arms and turned away from you, or grimacing or rolling their eyes, or simply not engaging with you, they won't get off their phone, right? That's obvious resistance. But it can also be a lot broader than that. For example, a client may make a statement of concern or hesitation or dislike. And that's an example of broadly resistance. So one area where clients often express this sort of hesitation or concern is around concerns about return to fertility, particularly with the IUD. Many clients have heard that using an IUD will negatively impact their future fertility. Now, what we want to do is roll with resistance. So instead of jumping too quickly to say something like, no, they don't, which is true, right? They don't, but effectively that tells the client, you're wrong, and that's not a great place to start. So what we first want to do is just normalize that concern, and we want to express empathy. So we can say something like, I've heard that from a lot of people, and I would really be hesitant to consider a method that I thought might impact my ability to get pregnant also. It sounds like maybe getting pregnant in the future is something that's important to you, right? This demonstrates to the client that you've heard their concern and that it's a reasonable concern. Resistance may occur if you fail to understand something very important to the client. For example, a concern that's really important to them about their contraceptive method or their goals around childbearing or preventing pregnancy, or with Keisha, for example, her clear statement that she wants to get her IUD out now. If we fail to demonstrate to Keisha that we've heard her concern, we can create this sort of tug of war dynamic. So we really just want to first accept the patient's position or roll with it, right? So we want to resist the temptation to jump right into problem solving or reassurance, which we want to do for Keisha, we really do. But we don't want to start there because patients can interpret this resistance on your part. They can interpret that as resistance on your part, and it can make them feel like you are invested or want them to keep the IUD. So it really sort of meets resistance with resistance, which is why I like this tug of war analogy so well. And that's really not a good starting place for Keisha or for any patient. So we could just say, I hear that a lot about the copper IUD, and I totally get why that might be frustrating. And so I always like to think of that as just dropping the tug of war rope. If you feel a tug on the tug of war rope, drop it. And then we can explore what the concerns are. Are they concerns about safety? Are they concerns about side effect? Are they concerns about future fertility? And it's our job to really create the space for the client to explore those concerns. I do want to say that rolling with resistance is often sort of misunderstood or mischaracterized as being manipulative or having the goal of ultimately getting the client to do one thing or the other, right? Like ultimately getting her to choose to keep the IUD. And that's not what we're doing here, right? in its truest form, rolling with resistance is a technique that is designed to create space for the client to explore their own desires, whatever they are. And it's often, I've often heard examples like, you know, if we roll with resistance, if we're a provider and we have a patient who smokes and we want them to stop smoking because there are very serious documented negative health effects of smoking. And, you know, we don't want to badger them, so we roll with resistance about smoking. We sort of leave the door open for them to come back and meet them where they are. But ultimately, we want them to stop smoking. So that's different. That's very different from contraception, because I want you to think about how contraception, from a reproductive autonomy standpoint, that we really ground ourselves firmly in the understanding that there's no preferred outcome other than helping the client to achieve whatever it is they want to achieve, even if we think a different decision would be in their best interest. So really it's about investing in the process of counseling rather than the outcome. So next time you feel frustrated or angry or annoyed with a patient, take a moment to reflect on what might be underneath that emotion and how it might impact the care that you provide or the patient's perception of that care. So you can focus on rolling with resistance to help you remain client-centered, where both you and the patient have equally valuable contributions. So we really want to think about how can we create space to elicit the patient's perspective, how can we build rapport, because improved rapport and this patient-centered approach leads to better patient satisfaction and adherence, and it's really the cornerstone of providing quality family planning services outlined by the CDC's providing quality family planning service guidelines. So let's go back to Keisha. She's expressed concerns about heavy bleeding. So I'm just going to put these bleeding patterns up on the screen for the different long-acting methods. I'm not going to read these bleeding patterns to you, but they're here just for you to remind you if you need a little refresher. But what I do want to talk about is patient experiences with bleeding and how we as providers or counselors respond to those concerns around bleeding. So I've heard many providers express frustration that clients aren't happy with bleeding pattern changes and emphasize that they were counseled about them on the front end. So we talked, like Nina said, we talked about this, you signed on for it, and now it's happening, and now they don't like it, right? I feel like everybody at some point has felt that frustration. So I do want to say that front-end counseling about bleeding is super, super important, and it does improve the likelihood that the client will be satisfied with the method, but it does not remove the right of the client to change their mind later, okay? So I want you to think to yourself, if any of you are Amazon Prime members and you really enjoy the feature of Amazon Prime of being able to return an item, no questions asked, right? You looked at the item, you contemplated buying it, it was well rated, you read the reviews, you thought about it, you bought the item came, nothing's wrong with it, but you just changed your mind and you want to send it back. And I remember in my younger days wanting to return something to the store, like being prepared with my excuse or the reason for returning the item, because you know they ask, like, is something wrong with it, and needing to have something prepared. And it's so nice with Amazon, you just send it back, no questions asked, and I know that you love that option. And we should think about, right, how that's so important, and it does probably make you more likely to buy stuff on Amazon because you are able to return it with no questions asked and no resistance, and we need to be doing the same thing for our patients. So let's do another poll. Based on all of that, right, what do we think might be the best starting point for Keisha? How do we want to start this conversation with Keisha? What do you guys think? I see some answers rolling in.
Connie, I was going to say from the presenter side, it's so exciting to see all the answers come in. It's
Isn't that fun?
exhilarating.
I like it.
I wish you all could see that part too.
So we have, right now we have definitely in the lead, yes, unfortunately, heavier bleeding is common with the copper IUD. Could you tell me a bit more about how the bleeding has been a problem for you and I can see how I can help? That is in the lead. We have a couple responses for remind Keisha that it's common and not usually cause for alarm, and it sounds like this has been really frustrating. We can absolutely remove your IUD today, and nobody has said offer options to help manage the heavy bleeding and encourage Keisha to stick it out a little longer to see if the bleeding improves. Okay, so I'm gonna give you, oh, look, it's over. No, go for it, it's over. Okay, so the winner from the poll is yes, unfortunately, heavy bleeding is common. Could you tell me a bit more? And I can see how I can help. Great. Okay, so let's talk about this. Ooh, hold on. So, remind Keisha that this is common and not usually cause for alarm. While that is true, what concerns me about starting here, because we do want to do this, right? We ultimately want to accomplish this, so that's absolutely true. But what concerns me about starting here is that Keisha may feel like you haven't heard her concern, that it's really bothersome for her. So we want to think about rolling with resistance, and we want to think about starting out by empathizing and normalizing. So the third option, yes, unfortunately, heavier bleeding is common with the copper IUD. Definitely normalizes that. Could you tell me a bit more about how the bleeding has been a problem for you, and I can see how I can help? So I think this is a great option. I would argue for the last option as even better. I do really like the third option, and that's where most of you voted. The last option, say it sounds like this has been really frustrating for you. We can absolutely remove your IUD today. So, A, it empathizes, and what it also does is it reassures Keisha that she is in control of her body, okay, and that you are not invested in the method or the outcome. The third option, to me, jumps a little quickly to problem solving. It does ask Keisha for what's going on, which is fantastic. But I think starting out by reassuring her that we are going to respect her autonomy is a great way to drop the tug-of-war rope and set up a dynamic that ensures Keisha that she's in control. And then Keisha's probably going to be more open to a conversation about how you might be able to help. So, you know, I love to share this example at trainings. I was providing some technical assistance on the phone to a provider who was really struggling. She was a provider of school-based health center, and she said, talking to me about this one student who had an IUD and came in, I don't know, like every 2 weeks or something, complaining about the IUD and wanting to get it out. To me, at the time, it was like, in my head, I was like, well, it's a little problematic that she's wanting to get it out, coming back on the regular and still having it, still wanting to get it out. But this provider said, you know, Connie, how can I get her to keep her IUD? And I said, you know, ironically, the best way to get her to keep her IUD is to stop telling her she has to keep her IUD, okay? Because again, you're setting up this tug of war and power dynamic. If she really wants her IUD out, we should take it out, obviously, but just the dynamic around making somebody feel like they have to create a good enough reason for you to remove the IUD really robs them of their own agency, and we don't want to do that. So there are lots of reasons why somebody might not want to bleed while they have the IUD. They could have a partner that doesn't want to have sex while they're bleeding. They might not want to have sex while they're bleeding, could interfere with their social activities. It could be that the bathrooms at school are really inadequate for privacy for dealing with heavy bleeding. It could be that the cost of tampons or pads are too much. So it could be a really big concern for her, and we want to make sure that we don't minimize it. So monthly uterine bleeding for some people could represent a cleansing ritual, an indicator of fertility, a time when they could abstain from sex, which could be a positive thing or a negative thing. And it really may impact work and other aspects of daily life. It could impact their budget, social activities, sex, safety, feelings of gender dysphoria. So there are lots of very significant reasons why somebody might have concerns about bleeding, and jumping too quickly to try to solve the problem and manage the bleeding this person might feel safer or better just taking that variable out altogether. And so we really need to respect that. It could also affect their participation in cultural or religious ceremonies. So what we really don't want to do is make patients feel like they have to fight to have their method removed. But many patients really do report feeling this way. So trying to convince someone to keep a LARC method once they've decided that they no longer want it is not client-centered, and it's probably ineffective. And it could damage your relationship with the client, as well as your relationship with other clients via word of mouth. So really, we need to recognize that patients do often face really significant barriers to IUD and implant removal. And as Nina mentioned in the beginning, thinking about programs that offer free LARC placement but not removal, we need to make sure that we're discussing access to removal during the informed consent process, because that may affect somebody's decision to choose to use an IUD or an implant. And we really want to emphasize that there's not a preferred duration of method use. So while these methods can work and be effective for a long time, for years, it doesn't mean that patients should or need to use them that long, or even that it's better that they use them that long. There's really no preferred duration, and that they should have access to IUD or implant removal whenever for whatever reason. And the onus really shouldn't be on them to create a good enough reason for us, right, to deem them worthy. I'm sort of tongue-in-cheek here, to deem them worthy of having their IUD or implant removed. So I'm going to turn it back to Nina to kind of walk us through some summary points.
All righty. Hopefully everybody can see this. Great. So just as we close, we want to review some of the tools that we've highlighted today about how to implement this ethical framework into our contraceptive counseling. So as we've already mentioned before, if my screen will advance. Uh-oh. Nope. There we go. Our frustrations and our elations can often give us a window into our own implicit biases. Also, by the way, that rhyme was absolutely on purpose. And so this self-reflection is something, like Honey said, is really helpful to just keep on as a daily tool, because this is really going to give us a view into what's going on under the surface. I kind of like to think of it as, you know, sometimes your stomach will rumble and you'll think, oh, I didn't even realize I was hungry. Like, that came out of nowhere. I like to think of it in the same way where, you know, for example, oh, I'm really excited that this person is keeping their implant. Why am I that excited about this? Or why am I so excited that they did leave here with a method, even if it's not the method that I would have picked for them? So using that as kind of the signal to move forward and understanding what's going on involuntarily. So here's some reflection questions. We've covered a few of these already, but these are just to think about after you've met with a patient and that process of thinking over what happened and what might be coming up for you. Something I think is really helpful to think about is the assumptions that you might have made. One that I often hear from providers in school-based health centers is the assumption that all of their clients that are coming in to talk about birth control methods are sexually active, or they're having the type of sex that can result in pregnancy. But again, remembering that some clients might be coming in to have the Mirena for endometriosis or taking the pill for their acne. There could be so many different reasons. but they've just come in making that assumption, which could be alienating for a client potentially. So, some best practices: get to know your patient, right? This is, again, one of the benefits of us being in a school-based health center, is that your patients know where to find you, right? You're there, you're part of their community. And so it gives us an opportunity to be really curious about their life and their goals and what they need. Remember, birth control is not the only issue. There could be so many different things going on. I'm sure you all have students and clients who, maybe they're facing housing issues, or they don't have access to nutritious food, or are in unhealthy relationships. All of these things can affect our contraceptive choices and how we view this type of care. So remember, there might be a little bit more going on there. This one I think is super key. Honor people as the experts of their own lives, right? We might have the scientific data, we might have the medical information, but our clients know what's best for them. And so this really means that our clients make decisions that, even if they make decisions that we don't think we would do if we were in their shoes, as Connie described, we want to make sure that we're not preventing them from making the decision that's best for them, right? That's something for us to work through, not for them to have to work through. Listen more than you speak. Probably a little hard to take seriously from us because we've been talking at you for so long now. But again, right, we can get a lot more information sometimes by just listening instead of speaking consistently. And we want to leave the door open. This one is so important that it gets a fancy little animation. They might not be ready to talk to you today or tomorrow or maybe even throughout this school year, but if they know that they can go to you and they will be respected, your clients will come back to you. And again, reflecting on our own identities and our practices can be really helpful in ensuring that we know what our biases are. So congratulations, you've already done that today. I'm sure you've all already been doing this throughout your work as well. So if you want to incorporate it into your daily practice, you can check that off your list for today. So in summary, patients can stop using a LARC method or an IUD or implant anytime they want. They want to focus on the process of the counseling, right, not necessarily the outcome. Want to regularly think about our own identities, our own practices, do that deep work, that self-reflection, so that we can remain client-centered. And as we wrap up, you don't have to share this with the group, but just something to think about for yourself is maybe something you learned today that you want to start doing, something you want to stop doing, and maybe something that you feel validated on where you're like, oh, yeah, I was doing that. Great, I'm going to keep doing that. Just for the record, we don't think you should be driving into the ocean. We just thought that this icon really did show that determination, but, I'd say one.
Keep on going in the direction you're going.
Exactly. And thank you so much for your time. Just want to let you know that if you do have additional questions about our training, feel free to contact us, and we have a ton of free resources on our website that might be helpful for you. So we're going to do a quick poll to figure out what additional resources might be helpful to you all, if there's anything that we can continue to provide. So please respond.
While you're responding to that, Nina, do you mind if I respond to one of the questions in chat?
Yes, please do. I apologize. I'm on a single screen, so Connie is my chat eyes and ears.
So someone chatted in when we were talking about the different options for Keisha that they thought option 4 was good, which was say, like, that sounds really frustrating and we can absolutely remove your IUD today. So they thought that was good, but it seemed like it should be followed up by something. And 100%, I absolutely agree with you. We just want to invite you to think about that as a starting place and thinking about how starting there and really setting the situation and the dynamic up so that Keisha knows that she's in control and that her wishes will be respected, sort of create a situation where you're able to explore options where she might end up deciding to keep her IUD. So she may be more open to having that conversation if she doesn't feel like she's going to have to fight for it. If she's reassured that, okay, she said or he said that I can definitely have my IUD removed today. So now I can kind of relax and kind of let my dukes down a little bit. And now I may be more open to having a conversation about options to manage the bleeding or something, for example. But really thinking about that as an important starting place to sort of set the tone and the dynamic.
Absolutely. Thanks, Connie. Okay, gonna end the polling. Hopefully you can see these results. It looks like patient education materials and counseling aids are the preferred option, as well as some clinic tools and templates and protocols. I'll say for the clinical tools, a lot of that's on our website, so please check that out. And that's good to know that some patient education materials would be helpful. So Connie and I will make a mental note of that. Okay. Oops, there we go. And then we have one more poll for you. Just let us know to what degree that you agree or disagree with the following statements, that this webinar actually gave you some new content and some new information to consider for your practice. Okay. Wonderful. So it looks like I'm going to share these in the spirit of transparency. So we've got some agreement, we've got some disagreement, we've got some we're not sure. But we thank you for your honesty and for sharing with us today. Advance slide. And that's it. Thank you so much for sharing your morning or your afternoon with us today, and thank you again to the School-Based Alliance for having us. I'm going to stop sharing, or Soma, you want to take on over?
Sure, 1 second here.
Slides are always the challenge.
Yeah. All right, thank you, Connie and Nina. Now is the time to enter any questions that you have into the chat box in your Zoom control window. And while you're entering your questions, we do have a few announcements that we would like to share with you. Please join us and become a member. The School-Based Health Alliance works to improve the health status of children and youth by advancing and advocating for school-based healthcare. Our members extend and support our work. Trainings like this webinar would not be possible without the support of our members. In addition, our members receive exclusive access to valuable program tools, timely publications, and networking opportunities. Please take a moment after this presentation to visit www.sbh4, that is the number 4, all.org/membership for more information and to join. Also, please visit our website to learn more about our upcoming 2020 National School-Based Healthcare Convention that will take place June 23rd through the 25th at the Sheraton Denver Downtown in Denver, Colorado. Join the School-Based Health Alliance, the Colorado Association for School-Based Healthcare, and your peers from around the nation for 3 days of engaging workshops, networking, and fun. The theme for the convening is school-based healthcare, elevating a school climate of health and safety. As a premier national gathering for our field, the convention is a fantastic opportunity to connect with hundreds of fellow school-based healthcare professionals and advocates from across the nation. So now we're just going to wait for any questions to come in. Alrighty, as we are short on time, just gonna wrap up here. If you do have any additional questions, please feel free to send them to the email displayed on your screen. That is info@sbh4all, that's the number 4.org. And again, thank you, Connie and Nina, and thank you for joining us today.
Thank you,
Thanks, everyone.